My name is Frank Jaskulke with the Medical Alley Association, and I'm your VP of Intelligence. And I'm so pleased to have you with us today for this great discussion on value-based care. We're going to have two discussions today looking at how value-based care has evolved, or maybe not, as a result of the pandemic and the introduction of virtual first care. And then we're going to have a discussion of some of the recent legal and legislative changes that hopefully are bringing value-based care forward a little bit faster. We've got two great panels to handle that. I'll be moderating the first panel, which will kick off in just a second. And then my colleague, Bobby Patrick, will moderate the second panel. This event is being recorded and will be made available as an on-demand webinar afterwards, as well as a podcast episode for those of you who like to bring Medical Alley content into your exercise regime, cooking dinner, or whatever else you might be doing. Throughout the event, the Q&A function is active. So if you have questions, please use the Q&A function. We'll be monitoring that. The chat function is also there, but the Q&A function just makes it easier for us to moderate the questions and incorporate them into the discussion. And so with that, I think I'll get started with our panel for this first part, looking at virtual first care and its impact on value-based care. I want to start by doing just some quick introductions. I'll ask each of our panelists to introduce themselves. So I'll maybe go in order of alphabetical order. And so Joe, if you wouldn't mind starting with telling us a bit about you and what you're up to.
Hi everyone, my name is Joe Connolly and I'm the founder and CEO of Visana Health. And Visana Health is a virtual first women's healthcare provider. We work with payers and self-insured employers to help increase access to quality care for benign gynecological conditions like endometriosis and uterine fibroids, and ultimately help women avoid unnecessary surgeries.
Wonderful, thank you for being here. And Taqee, if you would, introduce yourself.
Absolutely. My name is Taqee Khaled. I'm the head of client engagement at Nerdery. We're a services firm in digital business consulting, and we specialize in a number of areas, especially in digital health, where I've been working the last couple of years. I'm an epidemiologist by practice and have also worked in both payer and provider settings, as well as in large national consultancies in digital healthcare strategy. Excited to be here. Thank you, Frank.
We're excited to have you here. Thank you. And then Cheryl, if you would.
Yeah, good morning. I'm Cheryl Matter. I'm the Vice President of Population Health at LifeSpark. LifeSpark is a senior services company focused in home and community, increasingly moving into value-based care, where we support seniors and specifically partner with existing delivery systems to complement services and to manage risk over senior populations.
Wonderful, thank you. Well, it's so great to have you all here. And the first question I want to ask is kind of the foundational question for the discussion. So I'll ask it of each of you. But Joe, I'm going to start with you because I think you've become a little bit Twitter famous for this discussion around what is virtual first care.
Yeah, so the way that I think about virtual first care is just to highlight that it doesn't mean virtual only. So it's really about having an intentional selection of care that's matched to a person's clinical needs as well as preferences. So some of this care might be delivered virtually and other parts of it might necessitate in-person care. And I think the way to think about virtual first providers is just like you think about brick and mortar providers. So virtual first providers make sure that they have adherence to best practices as they relate to standards of care. We think about safety, security, privacy, data rights. And what we really strive to do is have complete solutions that support a person to take all of the necessary next steps in their health journey. So that's the way that we think about it.
And then Cheryl, I'll ask the same question of you, and from the perspective of working with the senior population, how does virtual care fit in there?
Yeah, absolutely. For me, I think about it a lot of different ways. I think for us, when we think about senior care, we think about a lot of continuity of care and the opportunity to help support people for in more of a longitudinal way. So it helps to create flexibility, access, and convenience. It also enables us to deliver services in a more efficient and effective way. So things that typically would have been in a clinic, but now we can start to think about how we can support them in alternative settings, lower cost settings. So I think it's really an important component of our model. That really helps to align the experience, the convenience, and also to promote access. So a lot of, as we start to think beyond the metro or some of the areas when we look at rural populations that might be challenged in accessing quality care. That's another opportunity for virtual.
Fantastic. I think continuity of care is something that's going to come up more in the discussion. Taqee, from your perspective, how do you see virtual first?
As a service provider in digital health, one of the ways that I really think about virtual first is kind of about a strategy of consumer optionality as well as consumer convenience being sort of the leading lens that organizations need to be thinking through. Because I think, as Joe said, it's not that everybody's going to go through that front door, but if you don't have it, you're absolutely going to be ill-equipped to holistically engage with folks. So I think about it as critical as an overarching piece of strategy, but not the sole pillar on which effective care and value-based care will be built.
Indeed. And now continuity and convenience are coming in. I want to talk about maybe a second foundational thing then that builds on that, which is, what is value-based care? What do we mean by it? Right? We all get, because we work in healthcare, that healthcare moves at a different pace from other industries. And we've talked about value-based care for a long time. I've been around long enough to hear people talking about capitation again. So I'd be curious for the group to talk about, what does value-based care actually mean in this sort of context where access, continuity, convenience are big issues? Cheryl, maybe I'll start with you and just ask, is the old equation of outcomes over cost still what we talk about when we mean value-based care? Or does it take on a different dimension?
I think for me, when I think about value-based care, I think about economic models that allow us to have more flexibility in the services to really meet the needs of the folks that we serve. So, yes, certainly around cost and outcomes, but in traditional fee-for-service, there really aren't models that support the delivery of a lot of the essential capabilities or functions that can contribute to the proactive wellness, health and wellness of an individual. So for me, when I think about value-based care, it's less about reducing costs and certainly about finding a model that rewards outcomes, but really creating that flexibility in the services that currently in an existing kind of fee-for-service system just don't happen because the economics to support that aren't there. So to me, it's an enabling capability to allow more holistic models of care that can be more proactive and supportive and flexible in meeting the needs of the members that we serve.
Oh, that makes a lot of sense. And Joe, I'll ask you that same question next, because I think what Cheryl described made me think of Visana and bringing more holistic care, but that doesn't necessarily fit the way we pay for or deliver care today.
Yeah, absolutely. I completely agree with you, Frank. And at Visana, what we try to do is, like you mentioned, bring holistic care to the patient. So lots of people don't have access to dietitians, psychologists, in our case, pelvic floor physical therapists. And so we have a wrapper of all of those different care services that we deliver directly to women in a digital-based way that increases access while doing so at a lower cost. So we think through what services should be delivered synchronously versus asynchronously. When can we, maybe a simple text message can get the problem solved versus, what actually constitutes a virtual visit or potentially an in-person visit. And I think so often we think about value-based care, and just like you said, Frank, it's outcomes divided by costs. But I think an often forgotten aspect is the member experience or the patient experience. So in almost every other industry, convenience is value. People certainly pay for convenience. We've seen, grocery delivery really skyrocket recently because it's just more convenient to the consumer. And so for us, when we think about virtual care, we want to make sure that we're aligning to a value-based care model and really pursuing those outcomes at a lower cost, which basically means making sure that any clinician, be it a physical therapist, a PA, NP, or a doctor, be operating at the top of their license, and that we're scaling the right patient to the right clinician at the end of the day. And I think if you're able to do this properly, then you can really expand access in the reach of high quality care, including in rural areas, as Cheryl mentioned earlier.
And you talked about the experience piece of it, and Taqee, I know that's an area the Nerdery does a lot of work in. And you guys have a nice perspective because you work with a wide range of companies. Are they looking at value-based care differently today than they were maybe a few years ago? And are they looking at some of those things like convenience or access or the experience and not just the cost and the outcomes part of it?
I think that's a really good question. And Cheryl, when you were speaking, I was kind of thinking of our shared heritage in sort of the payer space and kind of the things that we contended with in that setting, because I think when value-based care first came to the lexicon, I think there was initially a very much an institutional perception of value strictly linked to operational and fiscal and economic realities. And I see it kind of like almost like a rubber band or something that's sort of like stretched, and the consumer thought has kind of like, whereas it was kind of pulled back behind it, has sort of like whipped over and gone across, where, in terms of importance. And Joe mentioned, cross industry examples of how folks really in their day-to-day lives are valuing digital convenience first. And it's not just because of, it's not simply because of not having to expend the effort. It's also the physical effort or something like that. It's about, I think, a change in lifestyle as well, in terms of how people are struggling to make ends meet, also struggling to figure out what living through this transitional period in human society looks like. All of those things are sort of really compounding the way we think about convenience. So to your question, are folks in industry and cross industry thinking about that? I think they are thinking about it. I think they have yet to figure out how to reconcile it. One of the reasons that I think there is trouble in reconciling it is because there isn't a clear articulation of what ROX is, return on experience. So that's actually one of the areas that we just recently published an insights paper on, of just starting to think about how do you actually think about experience as a return vehicle, and not simply in the crass ways to say, oh, make people happy and they'll buy more, but what does value to people look like, and what is the Venn diagram of value to people and value to institution? And if you can link those two together, then you've got a really happy overlap there. And I think that is different for every type of organization. So for Visana versus LifeSpark versus Medical Alley or whomever, we all have a different fingerprint of what that overlap looks like. So right now with folks, I'm trying to help our clients think through exactly what that overlap means for them. So for example, I just got off a call right before this with a major payer on the East Coast who would love to innovate on digital front doors and wants to create the capability to bring 1 million new members into their system over the next 3 years, which is a lot. And so that the discussion that we really dwelt on in that conversation was this point around, how do you understand what people need? How do you understand what is something in their life that needs solving, and where does that intersect with something that you provide, and being really diligent about that. And once you can nail that with confidence, I think you can really start to iterate on what value means. You can start to look at the economics of value, and you can look at the experience of value, and you can do something robust. But if you don't invest in knowing where those overlap, then you end up creating disproportionate value for the institution as your primary focus, and then you lose people.
I mean, I think you're anticipating a bit of where I want to go next in the discussion around how the competitive dynamics change when we start to put into the equation, what the end user, the patient, the person, whatever, whoever it might be, the things that they value that are above and beyond, I'm sick, I want to be healthy. We had a question from the audience that starts to get at that, so I want to ask that one and then come back to it, which is from Eric Lucas asking, what do they see as the role of the healthcare consumer in being proactive in health engagement? Is it a problem or an opportunity? And Cheryl, I want to start with you on this one, because the senior population that's coming into what LifeSpark does, there's a new generation coming in, and I'd be curious if you're seeing, is it different today? Are they more proactive, and is that something that's an opportunity for LifeSpark or a challenge?
I think it's certainly an opportunity as you start to get, as seniors are becoming much more familiar with technology, there's more opportunity to engage them. I think starting to think a little bit about, their engagement in the system, why they are or they aren't, how they interact, what experience they're looking for. I think LifeSpark at its core is an experience company thinking about how we help people age magnificently. And there are a lot of, in my opinion, a lot of barriers to quality health that aren't care access related. There's everything from health literacy to trust with the system to knowledge navigating. And so the ability to leverage more tools to help to engage or activate, I think it's certainly an opportunity to create more touch points, to help build trust and longitudinal relationships, to help understand and really deeply understand who they are, who their support system is, what their needs are. We think that that's really critical in elevating, health is not one thing. It's not just access to services. It's a number of things that really elevate what people want, who they are, how they envision their life, that kind of motivate. And so I think there's such an opportunity, to continue to leverage that. And I see it as much more of an opportunity than a problem. I think it's really right for us to figure out and to start to build on that to really engage them more holistically.
And Joe, I want to ask you about this next, because I feel like Vasana is a company where the patient advocacy has really been central to what you're doing, but also just to the broader set of health issues for a long time. How does that proactive engagement play into what you're seeing?
Yeah, Cheryl, I love everything that you just said, and I completely agree with all of it. I would say the way that we think about it is we believe in a very high touch model, and we constantly measure engagement with all of our services, and we try to increase engagement with all of our services. We believe that having really proactive engagement is ultimately going to improve clinical outcomes, and we think through that from the lens of behavior change. So in our specific scenario, oftentimes diet and nutrition can be a major way to improve clinical outcomes. But the traditional way that the system goes about doing things is you might see your dietitian once a month, and then they make some recommendations to say, hey, maybe you should eat these foods or not these foods, and they'll give you a little pamphlet and you're kind of on your way and you're left to your own devices. We take a very high touch model that's very different than that, where we have coaches that are talking with patients synchronously and asynchronously almost every single day to make sure that they're being held accountable to in making those behavior changes that we know to improve clinical outcomes. And so by having this really high touch tech enabled model, we're actually able to improve clinical outcomes to what a brick and mortar provider could actually provide.
And I think we're starting to get at this crux of the issue that value-based care is getting redefined in some ways and kind of expanding the equation a bit. And the pandemic certainly has accelerated that. What I wonder, and what I suspect, many of the organizations out there that are in care delivery, in payment, in technology, is does the experience side, the convenience side, does it alter the competitive dynamics that we operate in, right? Like healthcare is a business, we're in the business of healthcare. Is the competitive dynamic being changed such that organizations that prioritize experience over time are going to be more competitive compared to those that are in a more traditional model of delivery, payment, or technology development? And I'll ask this of the group, and maybe did he start with you, that ROX you described, will that become a competitive advantage or disadvantage over time?
It stands to potentially become one. I think implicitly it is one in the current economy that all of us plan from a consumer standpoint, right? Many of us are based in Minnesota, the home of Target, or as we affectionately refer to it, Target Boutique, some of us. Very, very high quality consumer experience, something that they consistently are always thinking about their guest first. And it shows in terms of people selecting them in order to address the needs that they have. Where that set of principles hasn't hit yet is in healthcare, but it is completely changing every day in that regard. So the leaders early on were the firstborn digital companies in healthcare a couple of years ago. There were not enough of them, and they did not pilot in wide enough areas for people to really en masse think about what the value could be. But if I think about, for example, what my first line of clinical investigation is, even though I'm a member of a local health system. I take all of my children for anything that's subacute to a virtual visit on Doctor on Demand, for example. I do that as a matter of course pretty routinely, and the reason is that I'm in my head, I have maybe like a two-way graph, not explicitly, implicitly, and the graph says what's the the high-low factor on convenience and the high-low factor on quality, and somewhere in there cost is in there too. But since I am fortunate to be insured, I'm thinking a little bit more about the convenience and the quality. And so I think that will be the competitive battlefield, as long as folks can kind of line up the right sort of payer type of or out of pocket, reasonable out of pocket economics of these services or entities that deliver products and services in healthcare. You're going to see everybody negotiating, and we all are doing it today. We all have an implicit negotiation of, is it easier for me or is it as good? And so what we end up saying is, oh, it's really easy for me, but it's terrible. We never choose it. We won't choose it. We'll pass it by. But if it's really, really good and really inconvenient, we might choose it as well. But the sweet spot is highly convenient and high quality. And the more folks from the C-suite are focusing on those type of questions in health organizations, we're going to see that is. I mean, if you spoke to, for example, Scott Weber at who's the CMO and chief marketing and design officer at Fairview, he'd probably say, well, we're already there. That's absolutely where we are already, and people are making those decisions today. They're voting with their appointments already, whether we want to count those as those votes or not. That's what's happening.
Yeah, I like the 2x2 matrix you did, because I'm even thinking of my own experiences. I did a virtual visit for my cardiologist for the first time ever a couple months ago. And honestly, God, I don't know why I ever went in person for a regular checkup when there was no lab work or anything. Like 3-minute call, we were both happy, got the information we needed. Life was good. And while that's certainly not all of healthcare, there's a big segment that is that, and that experience is like, I'm doing this again. Cheryl, I'd ask you about the competitive dynamics next. The world you're in, there's I think of like senior care and the facility side of it in a very fragmented industry. There's also seniors are where a lot of the care is delivered, Medicare with near universal coverage. How does that world look, or how do you think experience might change the competitive dynamics there?
I personally think experience is going to be a big differentiator. In fact, we're betting on it, both in terms of outcomes and driving quality, but also member retention and really shifting the industry. I think healthcare is a laggard, in my opinion, in terms of really understanding, and probably because of some of the economic models where the member really hasn't been put at the center, and because of the way money flows, their experience hasn't been prioritized. But I do think when you look at the environment, expectations amongst our members are changing. Just digital across all of the platforms they use, it's just starting to shift in terms of what their expectations are, and we have to kind of meet that. I think, for us, being able to create that continuity, understand what matters most to our members, and then to be able to kind of meet them where they're at across different capabilities and channels is truly different. And that is going to be something that once they experience it, how different it can be, I think it will be something that will force people to change the approach. And really, especially when you think about like Medicare Advantage and competitive nature within those plans and programs, I think that will be a true differentiator and will influence the market, absolutely.
And you said something in there that really struck me, be aligned to the patient or the incentive side of it. We all know, because we work in this, that healthcare moves slowly, and in some ways that's the right thing, right? If you do something wrong, people get harmed. Another person had told me healthcare is super responsive to incentives, that if the incentives change, it tends to move really fast. And for those of you who are going to be on the second panel, I think that's what we'll hear quite a bit about, of how some of those incentives may be changing and what that may portend then for what we're all doing. But Joe, I want to ask you that competitiveness question of how do you think the competitive dynamic changes if we start centering more of the activity on experience, not giving up outcomes, not giving up on cost, of course, but having a third variable in the equation?
Yeah, I personally have a thesis around the fact that I believe the battlefield of the future is going to be the consumer experience. And I think that's what we're all going to eventually compete on. And I think that we're already starting to see different stakeholders within the industry beef up these specific capabilities. So when I look at the payer space, I've seen lots of payers very quickly get into the virtual care delivery space. I've seen Mayo Clinic and I believe Kaiser invest in a home care delivery company and be a hospital at home and almost disrupt themselves. And so people are very much thinking about how they could start to invest in these capabilities. And one trend that I've begun to see in the last year or two is the creation of virtual first HMOs, where they've taken the old HMO model and they're now saying, hey, you can get free visits through Doctor on Demand whenever you want on demand. And then Doctor on Demand helps that payer then control downstream utilization, as well as making sure that the patient has a great and seamless experience. And I think in the future, where brick and mortar providers used to believe that there were certain services that could only be delivered in person, and that might be true, but we've seen the rise of what I call API first companies that are actually delivering different services in person that are on demand that virtual care providers can order. And so, for example, as a virtual care provider, I could order a lab draw that would be done in the patient's home. So they would actually send a phlebotomist to the patient's home, draw blood and send it to a lab, and then they could upload the lab results to my virtual provider's EHR and see the results right there. And so all of a sudden now you don't even have to leave your home and you can get all the care that you would need, even going beyond just the simple virtual visit. And so I think we're going to see, in the next 5 or 10 years that we'll see a big consolidation around the consumer experience and people really thinking through what a best in class consumer experience looks like, because ultimately consumers get to pick where they have care. And so if they're making that choice and that choice is inextricably tied to revenue, we're going to have to compete on that specific metric.
Yeah, I'm starting to hear kind of the second order effects of virtual care, that just like when the iPhone came out and smartphones started to become ubiquitous, all of a sudden there were businesses you could build, things you could do that just didn't make sense before. It's starting to feel like healthcare is getting there as well, that the API companies, these different platforms, are making it possible to disaggregate and re-aggregate healthcare as we know it. Doing that to 20% of the economy will probably take some time. But there was a question in the audience that, Joe, you kind of started to get at, and I suspect you work in this here, so I'll ask you, which is about continuity of care and the fragmentation. So we have this wealth of great new companies coming up, new technologies, new services, new ways to get and receive care. Interoperability has been a thing in healthcare, or not a thing for a long, long time. Is fragmentation a concern? Are we addressing it, or how does that play into this whole value-based care discussion?
Yeah, I think, the upshot of the era that we're living in is an era of tremendous and rapid innovation and choice between point solutions. And the downside of our current era is effectively the fragmentation that you referred to. I have thought about it in a lot of different ways. And I know a lot of smarter people have as well. I feel like, as Joe referred to, there'll be some serious consolidation that happens later, but it's going to be, there was an initial era of it that happened right after the passage of the Affordable Care Act, where there was a bunch of middle market moves where people said, oh, I want to buy this, acute care facility and this outpatient facility and this whatever. And they were sort of like smashing together like a lot of these different businesses and saying to themselves, well, there's a lot of beads on a string when it comes to the journey, but maybe I will be responsible for these three and these two. And so there was some institutional purchasing of actually brick and mortar that happened. Well, enter rapid digital health over the past, 6 years of massive investment that's constantly been a record year every year. And now you've got a bunch of these other solutions, and everybody's saying, well, I'll solve this pre-auth thing. I'll solve this, coordination of care thing. And I kind of looked to a conversation that I had with the VC even a couple of years ago, who was really trying to push their thesis of, contiguous portions of a care workflow or care journeys being housed inside of entities more cleanly, right? And so that's now what you're seeing with more holistic aspects of where value can be captured, where, if we transported and found, Joe Prime like 10 years ago, he probably would have been thinking in a fragmented way. But Joe today is thinking about complete integration, right? And that's how the value return is going to occur. There are places, though, where all of us, from a digital standpoint, need to think about what's the bridge into the traditional brick and mortar, because that will still be sort of kind of an open question mark. So if you take a major health system in our region that provides all the typical services, but maybe is losing market share to Walmart and CVS and all of those sort of options, and express and urgency room and et cetera, they're saying to themselves, well, at some point, if this patient moves from being able to conveniently, get to these services or doctor on demand or what have you, and needs to bridge into my system, how do I have a complete picture of like what even happened? So there's two issues. One is making complete, newborn digital companies kind of making complete sets of solutions in and of themselves to have a complete value proposition for at least the part that they're responsible for. But then there's like this big chasm of how does that whole ecosystem of all those things actually eventually, if somebody, needs to get some major procedure that will always perhaps be housed in a traditional hospital or acute care setting, how do we make sure that that whole set of stuff kind of gets in there? A microcosm of that example, absent any of, modern innovation, is just think about antibiotic prescription in dental versus medical. We just never, you go to a dentist and you have an abscess, you can get prescribed for something, and it might not never ever connect to your healthcare provider in any way meaningfully. And so, that separation of ecosystems, if you take that analogy and take it into, and say the dentist is digital health providers and the doctor is traditional, brick and mortar medicine, it's a similar separation. I think there's going to be some players entering that space and are entering that space in terms of seeking to link that. And we're still not there yet.
And Cheryl, I'll ask you that as well, because from what I know of LifeSpark, you all are really in the middle of a lot of this, where you have the physical facilities, you have the virtual side, and you have patients, customers, whoever going from different sites of care throughout their journey. What is that like in LifeSpark?
Yeah, when we think about fragmentation and continuity of care, it's particularly problematic within a senior population. You're talking about frequently polychronic, multimorbid. They have a slew of ologists that all need to communicate with each other. You think about just even one acute event. They have a care plan. They have multiple medications and services that they're receiving. They end up in the hospital. They see another provider in the hospital, moves into a TCU, another provider group in the TCU, all developing separate plans of care. They get discharged home. They see home health or some other service that doesn't have a lot of that information. And in many cases, you end up with low value care, possibly very risky behavior in terms of just understanding, coordinating, and managing. And during all of those sites of care, you might still have a primary care provider that in many cases through this whole episode, which could be months long, they have no visibility into what was actually changed. And the patient comes back to them, months later, and they have to spend, 2 or 3 months correcting a lot of the care plan changes, because, the knowledge and the continuity of really understanding who this member is, a lot of the history, and then understanding what matters to them too, because there's a whole other set of kind of questions around who is this person, what matters to them, what are their values, what are the services they want, who are the people around them that support them, how does that contribute? So LifeSpark has been investing pretty heavily in really filling those gaps in those services, both from like a tech enablement. We talk about like an electronic life record, which is really trying to provide that 360 view, being smart as we start to engage in creating those longitudinal relationships so we can communicate and know all of the care team members and continue to update them and update all the plans of care. So even as you're thinking about an acute episode, that becomes really important. The other thing that's just, I think, very critical is, I think when we think about virtual first and the continuity question, we're talking about almost in some cases, a transactional event, like something happened and now we need to communicate that. But that doesn't always work within a senior population. I mean, more frequently, it's chronic conditions that are being managed, and we try to put chronic conditions into a transactional or an episodic framework, and that just really doesn't serve our seniors very well. So, LifeSpark's kind of right in, like, this is the heart of, I think, part of the problem that we're facing is that connection, that continuity, and being able to bring that holistic team together to be able to address and connect all of those dots to really best serve our member. Because, when we screw that up, which happens frequently, in our system today, people can die. I mean, it's very, very serious. So I think it's not just from, it's really everything, right? It's the outcomes, it's the experience, it's the connection points. It's with all of the different stakeholders, from the members, the family, all of their care team providers, and just making sure they're all on the same page. So this is a big thing to take on. And I think it's at the heart of what we're trying to do at LifeSpark.
Yeah, right on. And that's a good point. I want to acknowledge a good comment that was in the Q&A about something you said, Cheryl, that even though the value-based care equation seems to be changing, the outcomes still matter, and helping a patient to improve their health, even when it's a challenging environment, is still at the core of the mission of what we're doing. Joe, I wanted to ask you kind of that same question, though, because the business Vasana's in, like, a lot of it's chronic conditions, it's not acute episodes, and it's with generally a different patient population. What does that continuity mean in the people that Vasana works with?
Yeah, so I mean, it actually doesn't look too different than what Cheryl just described, where you need a really holistic set of stakeholders involved. So if we think about traditional gynecologists or OBGYNs, they might not have a nutritionist on staff, a pelvic floor physical therapist on staff, a clinical psychologist on staff. So you've got a member who's really just going from office to office and kind of ping-ponging all around the different healthcare system, and these parts might not really be talking to each other as it is. So by creating a multidisciplinary care plan, we're really able to improve outcomes and improve the experience and have all of that within one place. And we definitely need in-person providers to provide a large aspect of our care for things like IUD insertion that might be needed. And we obviously can't deliver that digitally right now. And so we do need that continuity of care for in-person care services. And fortunately for us, there are actually vendors that are trying to solve this issue right now of breaking down the different barriers between EHRs and health systems and virtual providers. And so companies like Redox are actually creating a standardized way where we can communicate to one another and actually send all of the information in a very interoperable way to try to overcome some of those barriers.
And you start getting at another, I think, important point around specialty care. And Cheryl, you touched on this as well, that we do often think about primary care as what all of this is about. And Taqee, I might ask you, what does this look like beyond, or maybe in between primary care and I've got to go to the hospital, or there's something that has to be done in a physical place? What's going on in that world, and how does value and virtual care play out there?
That in between space is still getting worked out. I think what you're seeing is kind of like a little bit of I would liken it to, like, in like a cave, you have like stalactites and stalagmites that, like, you have some that, these forms that drip down from the ceiling and form these spikes from the top, and then they kind of form from the bottom as well, and they kind of meet in the middle. You're seeing, for example, Walmart rapidly expand locations, rapidly expand services, and then also move directly into insurance. They're never going to go into a space where they're doing like an open heart surgery or anything like that ever. It's never going to make any sense. They may offer convenient on-site chemo. Who knows, like how that type of stuff could work in the future. I'm not going to speak to the, to what's, the upper limits of what's possible if there's convenient and good technologies that coincide with consumer experience, but we know that they're not going to be able to go or want to go really upstream into those spaces that hospitals are squarely set to do. I think this, it really depends on the hospital executive that you speak to, but there are some that would like to not be the stalactite. There's some that would actually like to hang back and say, you know what, I'll give up that share of market. I'll go ahead and shrink all of my primary care clinic, square footage. In fact, I don't even have any profitable way of maintaining it. So if you all are serving the people better, have at it. I just want to know the, holistic view of what's happening to folks when, they come in to that next setting that we serve. And I think a lot of them are thinking really carefully about multi-sided partnerships that will, effectively create the care flow that's necessary. So it's not, for me, I don't see all of that happening yet. And one thing we didn't talk about today yet necessarily is that there's also this juxtaposition of a massive home health movement that's happening, obviously. Mayo's created the home health platform, mHealth Fairview started offering at-home chemo months and months ago. And I think the Wall Street Journal about 2 months ago did a roundup of several different companies that are all, moving in the home health direction. I think one thing to think about across all of that is the equity question, which is that, technology has shown itself in Rock Health's recent analysis to unfortunately suffer the same pernicious sort of like equity differences that we see across a lot of other areas in society. So it actually breaks down really cleanly on whom you think and presume may or may not be able to have as ready access as whom you think would. And so we do still need brick and mortar. We still need highly convenient brick and mortar. Not everybody will feel comfortable with care coming into their homes, and not everybody will be able to have the right kind of data and cell phone plan or tablet plan to be able to, do the virtual. So again, going back to the original point, I think that Joe made, virtual is an avenue, and it is an avenue of a modern healthcare organization to be able to serve. But if value is to be achieved, we have to take that target mindset of like, oh, you left a shopping cart over here, kind of unfinished. Let me pick it up for you over here. Or you had to go pick up your kid from this appointment. Well, why don't you have us do it? Why don't you pull into a drive up spot and move pick up your cart over there instead? So we need to think about that in healthcare, I think, and that's still being figured out.
Thank you. And I think that's a great place to wrap it up. We're coming right up on time. You painted a great vision of kind of what's going on and some of the patient experience. I want to say thank you to our panelists for that just fantastic discussion. I learned a ton. I really appreciate your time. And I'm going to hand it over to my colleague, Bobby Patrick, for the second part of the program. Enjoy. Bobby, the floor is yours.
Great, thanks, Frank, and thanks for leading that really interesting discussion. Great panelists and really teed up this conversation nicely, talking about the direction that value-based care is moving. And this conversation will focus a lot on the regulatory space that is enabling some of that movement, or in some cases hindering it, and what else needs to be done. So welcome everyone to the second panel. Again, I'm Bobby Patrick. I am the Vice President of Strategic Growth and Policy for the Medical Alley Association. And I have the honor of leading this panel that will talk about recent changes to the Stark and Anti-Kickback statutes and opportunities for patients within that value-based care framework. So I have a great panel with me today. And so I'm going to let them each introduce themselves. So Nichole, let's start with you. Introduce yourself for everybody.
Thanks, Bobby. Good morning, everyone. My name is Nichole Mitchell. I'm the Chief Operating Officer for the Allina Health and Aetna joint venture. We are an innovative health plan here in the Minnesota area that combines the national expertise of insurer Aetna, now CVS Health, along with the clinical expertise and footprint of the Allina Health network and infrastructure. Excited to be here and welcome the discussion.
Great, thank you. Ashton?
Hey, I'm Ashton Boon. I'm in-house counsel at Mayo Clinic located in Rochester, Minnesota. In this role, I address regulatory compliance questions across the enterprise, including Stark and anti-kickback questions. Mayo Clinic is a nonprofit organization committed to clinical practice, education, and research, providing expert whole person care to everyone who needs healing across our sites in Minnesota, Florida, Arizona, and Wisconsin.
Great, thank you. Dave?
Sure. Hi, I'm Dave Alt. I'm counsel at Taqee Drinker. I work heavily in the Medicare, particularly value-based care space. I come from HHS, from the General Counsel's office, working on Medicare reimbursement, and then more recently from CMS's Innovation Center, where I ran their ACO models and Part C and Part D models. So spend most of my days thinking about a lot of the issues that you've been hearing about over the last 45 minutes, particularly in the context of the organizations that are interacting with CMS for their Medicare programs, and particularly in the fee-for-service space.
Great, thank you. And then Matt?
Sure. So I'm a colleague of Dave's at Taqee Drinker, and I'm in the healthcare practice here. And I've spent almost my entire career working for both payers and providers, doing network contracting and building reimbursement models, starting way back in the early 90s when capitation started to take off, but because they really didn't have the data feeds that they needed for capitation to survive, it ultimately waned and died, but now we see it's back. I think we have data and information to thank for that.
Great, thank you. All right, so we'll jump right in here, and we'll start with we'll start with a broad-based question and sort of take it from there. So, the changes that this discussion is focused on were finalized recently. They took a number of years to get to that point, and it happened sort of right around an administration change in Washington, and that often leads to reconsideration of recent rules, or sort of digging back in a short time frame, as we saw recently with the Medicare coverage of innovative technologies rule. And so let's start with that. So Nichole, how will these rules change, if at all, with the new administration, and how does that play into the consideration of payers and providers as they're sort of looking at how to adapt these changes within their business model?
I think these changes were really well suited to shifting the conversation from a transactional one, so from quantity to quality. And I think we've all wanted to do that over time, and that's how we start to think about value-based arrangements. The challenge is going to be, I think, that we have sort of a long runway as it relates to payer and provider contracting. And these are longer term agreements. And so with the change in administration, and we've already seen sort of some pausing and maybe some peeling back of some other initiatives that happened around the same time as the reforms to Stark and Anti-Kickback, I think we're going to have a little bit of hesitancy on the part of providers and health systems to really embrace contracts that include these rules, because I think, it's a pretty significant change in some cases for provider systems to change their entire workflow for something that they may potentially then have to reverse course on later down the road if there is any kind of pause or repeal or sort of a semi-repeal, which then results in having to open that contract back up to have those negotiations and discussions again. So I think until providers really get comfortable with the stability of these changes as we proceed throughout the course of this administration, I don't know that we'll see significant change happening very quickly.
Great, and Ashton, interested in your perspective on that. Coming from Mayo, how do you see that these rules playing into contracting with the new administration?
I completely agree with what Nichole stated. I mean, it's a long runway when it comes to negotiating with payer partners. However, what is wonderful about these rules is that it doesn't just limit us to a payer. We can contract with other groups that are going to be impacting that care of the patient. So a skilled nursing facility, or trying to innovate with a community paramedic. And I think what the providers across the healthcare industry is grappling with right now is, one, are these going to stick, or will they be amended by the new administration so we can take our first step or our fifth step into this value-based space? And what opportunities are there to really focus in on these target populations that really need innovative care models that were prevented from happening before these rules came out?
Yeah, that's interesting. So Matt, I want to hear your perspective here, given your experience, and then Dave, will go to you, and then I'm going to add another question on top of that. But as Ashton pointed out, there's more flexibility to go beyond just the traditional contracting between payers and providers and bring in other players within the frameworks that were set up here. So just interested in your take.
Well, I would say that I think that in my daily practice, I'm surprised usually at how unsophisticated some of my clients' arrangements are with payers, and then there are others that are very far advanced. And I think it tends to be a function of geographic region. A lot of my West Coast clients are, and have been for many, many years, deeply involved in value-based and risk-based arrangements, whereas in other parts of the country, they've just not taken hold. So I think that, when CMS put the pause on the direct contracting model, which Dave can expertly speak to literally, I agree with everybody else here that, geez, it starts to make, providers and plans rethink, well, is this value-based thing here to stay or not? I think, though, and I work largely in the commercial space, right, as opposed to Dave, who's heavily involved in government programs. I think that the commercial payers will nonetheless continue to dabble in this, at least in near term, and try to at least incorporate some kind of value-based component into their compensation and participating provider agreements.
Great. And so Dave, I'm interested in your take on this question as well, but I'm going to add a layer on top of it and ask you to address both. So, how do you think they did with these rules? Did they accomplish what they wanted to? Did they leave things on the table? These rules were in progress for a long time, and I think, as Frank noted in the previous panel, the discussion of value-based care has been ongoing long enough now that some original concepts are sort of coming back around. And so, just how did these rules hit the mark, or did they not?
Yeah, so that's a great question. I think they hit the mark in a lot of ways. This was a long time coming, right? That for a while we only had the flexibility in the government payer space, so in sort of the Medicare ACO space, to have these kinds of relationships. And so to be able to open it up and take it more broad with the exceptions, that are provided in those rules, I think is huge, and it's really encouraging the value-based arrangements in that space. And I think the timing is appropriate too, right? That a lot of the providers that were strictly fee for service or strictly being paid on volume are the ones who got hit the hardest. And so I think we're seeing a lot of that coming together, and that was a big piece behind wanting to open up the flexibility in these arrangements with various players. And I think that so I think that they hit the mark there. I think that with any regulation, and particularly in this space, what's left on the table is what's between the lines. So, and you read these, whatever it was, 1,000 pages of regulation, and at the end of it, Matt and I are talking about it, and we're still not exactly sure for a client exactly what they can or can't do. And so, that kind of piggybacks on what Nichole and Ashton and Matt were saying in terms of stability, right? That you know, are you going to be willing to enter into some of these arrangements and maybe take some of that risk when you don't have a real understanding of it, and when the way an administration may interpret that understanding could change too? So, right, the Trump administration may have drafted these regs with, you know, one idea in mind as to how they could be implemented and used by organizations. And this administration, you know, I expect in many ways will be more conservative in that approach and what they would allow. So I think that until the dust sort of settles and we have some sense of that, there is going to be some amount of reluctance. So that's definitely a place where there could be improvement. And, you know, of course, nobody wants to run afoul of OIG, and oftentimes at the end of the day, it comes down to, well, it would be great if we could do this as an organization, but it's just not worth the risk, right? And so I think we're still a little bit in that space and can move further down that road. The other thing that I think it is really useful here, and where I think they're going to be embraced by this administration, is that, you know, we're hearing time and time again that health equity is going to be front and center, right? And addressing health disparities. And so to the extent that these kinds of relationships increase access to care to vulnerable populations, you know, I think that that's where we are going to see maybe even increased leniency, and, you know, really the ability to bring in the social determinants or the drivers of health. I think that we're going to see a lot more flexibility in that area in this administration. So I think this was all kind of come back around. I think it was great. It was a good starting point. It was a long time coming, but I do think that there is more that could be done to kind of nail down these regs.
Ashton?
Yeah, I think Dave nailed it. Where these are great, they're a huge step forward compared to what we saw in Stark in 1989, and it's because it was all fee for service, and it's night and day where the industry has gone since then. But as Dave put it, and it's true, these rules are incredibly complex, and I think most of the provider systems out there are still combing through them and hoping, gosh, hopefully one day I'll get an advisory opinion to know how these rules will be applied, and that will make me sleep better at night as we're having these innovative discussions, because everyone is so excited about this door opening, but it's how much of the door has really opened, and we don't want to put ourselves or misalign ourselves with what has really become available with these rules. So I think there's a lot of wait and see coming, and once we get a bit more information from how these will be applied, I think a lot of people will be more comfortable.
Yeah, and so I'm going to go to Nichole in a second, but Ashton, I just want to follow up on that. So, you know, Mayo's setup is obviously, you know, a little bit different than a lot of other providers. And so I just wonder, you know, and this can be a short answer, of course, but, you know, how within Mayo's scope, you know, did these have a significant, especially the Stark law, did those have a significant impact on how Mayo is doing things, or was it just sort of around the edges and you're waiting to see sort of how they move into the next phase here?
Yeah, so since we have employed physicians, we don't have as many Stark concerns that pop up. However, we're doing a lot of innovative, as the last group talked about, we're doing a lot of innovative discussions and implementations with external partners. And so that's why we need to be mindful of Stark as well as Anti-Kickback, because of the collaborations that we are going forward with to really address the needs of the community and the patient populations that we serve.
Very good. And Nichole, you know, I obviously I want your answer to the broad question, but sort of similar to Ashton, right? I mean, Allina Health Aetna is a joint venture. And so it's set up and impacted a little bit different by how these rules apply. So just interested in your take as to specifically there as to whether, you know, how it really impacted your operation.
I think we're still doing a fair amount of assessment on that, right? Like, I think we're thinking about it in terms of creating a framework that enables flexibility to keep moving down kind of a glide path to more financial risk as it relates to interfacing with both of our owners, quite frankly, and thinking about in the course of that contracting work, how can we create a framework that's broad enough to encompass new innovative ideas that either of them want to do within that framework, without feeling uncomfortable about the level of risk that they might be subjecting themselves to. So if that, regardless of whether that's a focus on social determinants of health, on really touching on how we can get some better alignment in terms of, smaller, more focused networks, and really thinking about what levers can each of our owners pull in a compliant way, of course, in order to ultimately reduce that total cost of care. I think in some ways, we want to move forward and think about these broader, more intricate value-based arrangements. But I think we're going to have to start with some of the most basic that we've ever done where it relates to reductions in total cost of care and enable that flexibility between our owners to be able to adjust accordingly as they feel comfortable to impact that cost of care.
Yeah, and the purpose of those two laws, right, is to reduce fraud and eliminate misuse of funds. And it sounds like from your answers that maybe unintentionally it reinforced that by almost keeping it complex enough that it's just going to take a while for everyone to figure that out, which is not necessarily the worst outcome from it, but certainly maybe it didn't go make things as clear as they were sort of hoping in terms of pushing value-based care forward by removing the regulatory obstacles in the short term. So let's, and Matt, if you have any comments on that, I'm interested in those, but I want to toss another question out to you as well. Multiple sectors weren't necessarily impacted or didn't go as far to loop them into these arrangements as perhaps they thought they should be, or as others thought they should be, clinical laboratories, medical device companies outside of digital products, and then pharmaceuticals. So I have a couple questions here, but I don't want to stack three on you. So I'll just do one first. Were any of those exclusions surprising to you? And if so, which ones?
No, actually, I was not surprised by those carve-outs. I think that, with respect to the pharmaceuticals, it's tough to build a value-based reimbursement model around drugs because patient compliance and efficacy of the drug are going to vary so greatly from patient to patient that to come up with metrics that measure patient outcomes or patient health tied to just the drug itself, I think is tough without also incorporating, the ordering physician, the pharmacist. I mean, you have to involve a lot of people, I think, to impact drug costs. And same with respect to PBMs. I think that, as we all know, that's been an industry kind of rife with potential for fraud and abuse, whether it's with respect to, rebates or discounts. And I think for almost the same reasons, I think that it would be hard to include a PBM in a range. Well, you can include them, but they can't be part of the risk share arrangement. So I was not surprised at all, really.
Great. And so Dave, same question to you there. Any of these surprising to you, or they sort of follow script of what you assumed would happen?
Yeah, no, it doesn't surprise me at all for the reasons that Matt said. But, also going back to what you said a moment ago about, it looks like they're taking it slowly. That's exactly what they want to do, right? That, especially when it comes to, preventing fraud, it's much easier to open things up slowly and be like, we probably could have and should have gone a little further here and go further than go too far and try to rein back. And so what they want, and this is the same as this started with like the ACO models and the waivers, the fraud and abuse waivers, right? Is, start small and see what the outcomes see. Are you seeing fraud? Are you seeing, gaming of the system in any way? And if the answer is yes, then you correct it. But if the answer is no, then maybe you can go a little bit further, right? So I think that there is very likely a vision for how it could be taken further, but it's not all going to be done at once. And on the drug piece, it's exactly right that, at the Innovation Center, we can try to come up with drug models all the time. And when you're trying to bring in that, that the patient care to the quality and the outcomes to it's so difficult to do, right? And so once you take something out of that sort of, total patient and total cost of care arena, it's really hard to find a way to build it in.
Yeah, and so Nichole, I'm going to go to you next, and I just on the drug piece, the interplay of drugs with the new digital, adherence products and just things like that. It'll be interesting to see as things move forward if they're able to identify a way to sort of work all of that together to find a way to build a value-based arrangement there. But to sort of move that direction, Nichole. So obviously same question, but then also if one of them. So, thinking laboratories, medical device, pharmaceutical, or another one, which one would be most valuable to patients if they were to in a future revision, work one of those sectors in?
I mean, oftentimes when you're thinking about the consumer, cost is obviously a significant factor. And if you look at kind of that laundry list of things that were excluded, I think pharmaceutical cost is something that obviously has been very significant to folks. But again, it's really, really difficult. The dependency on the member behavior, the patient behavior in terms of adherence and compliance makes it almost prohibitive to be able to engage in any kind of value-based arrangement. And I mean, look, quite frankly, if you look back on kind of the list of those items that were left out, those are items that have been areas of focus for OIG for quite some time, right? I don't think anybody was surprised that as they start turning the dial, so to speak, that those would be some of the last that they would embrace in terms of kind of opening those up for opportunities. And I think if we ever get to the point where they are under consideration, I don't think it would be a very widespread opening of the door, right? I think it would be more of a sort of ratcheted approach. Once they can figure out what does a value-based arrangement look like in those arenas.
Great, Ashton.
I think all of them would be great for a patient. It's just how do we do it? Because I think it's just disappointing that we don't have the opportunity to at least try while protecting the Medicare trust fund, while not trying to impact or overutilize care. So for instance, a PBM, most of our patients have issues with medication adherence, as Nichole even mentioned, and seeing multiple physicians and lack of care coordination where they're getting prescriptions that are contraindicated. So would there be a way for the health system to partner with the PBM to help manage a target population and drive forward the best value in terms of prescription drugs for that particular patient, and then we share in the savings by cutting down ED utilization or readmission because the patient actually knows what meds they're taking? I think that would be great, and I think that would truly lower the cost of care, not incentivize overutilization of meds that they don't need. But there would have to be definite guardrails. But I don't think we're ready to take that more. I wouldn't say step forward. It's like a leap forward in trying to figure out how do we best support patients and also make sure that we're not creating any type of fraud and abuse concerns as well.
Yeah. Okay. That's really interesting. Thanks to all of you for that. So Ashton, I'm going to start with you, and then I'm going to move to Matt on this one. So the initial rule, as I noted earlier, was drafted and comments were due a long time ago, I think New Year's Eve 2019, and feels like lifetimes ago at this point. And and much, if not all, the stakeholder input was completed, right? And so two questions again, and I think we'll start. I'll ask both, and you can comment on either or both. But how is the acceleration in providing care to patients remotely? And this was a big discussion in the previous panel. Or within their homes, how has that been impacted by these changes? And then, what modifications to these new safe harbors, or frankly, new safe harbors, would be beneficial to patients, knowing what we know now that we didn't necessarily have as a reality when we were first working on this?
Yeah, so I don't think anyone truly anticipated. Everyone knew that the requirements for delivering telemedicine needed to be changed because no one would meet the distant site or originating site provider or be in the right placement in the rural community to be able to actually submit a claim for billing. So we definitely needed these waivers when it came to the pandemic to make sure that telehealth can be launched. And it's been critically important to keep patients out of the hospital, especially now with the pandemic. I think with these new safe harbors, exceptions, we're seeing the ability to continue to coordinate care and keep patients out of the hospital as much as possible. But I think where I'm seeing potential concerns is that some of the limitations when it comes to safe harbor, like the $500 limitation for care and support, I don't know if that's enough to be able to make sure that we can manage a Medicare beneficiary at home and really keep those costs down from a value-based arrangement. So I think that, again, we're moving in the right direction. I think the pandemic has shared a bright spot of how these collaborations can work because we've all had to come together to manage this patient population. But once the pandemic slowly moves away and we're back to no waivers and just these rules, I think we're going to be stunted with the ability to further collaborate.
Matt?
Yeah, so I totally agree. And I think that what I would, like to have seen or see going forward based on the experience we had with telehealth during the pandemic is something to get built into these new rules that is analogous to what some of the CMS and CMMI models have around telehealth visits and, decreasing the requirements and expanding the coverage, and even a continuation of I think there's some type of a bonus payment now during the health emergency for physicians during telehealth visits. I think to see more of that involved in these exceptions would go a long way in terms of where delivery is going anyway. And well, I guess that's it.
Very interesting. Dave, anything to add there or build on?
Yeah, no, I think that, one thing that's come from the pandemic is, in the world of, digital health and telehealth, there was a lot of skepticism before at CMS that Medicare beneficiaries would use it or would want to use it or would be able to use it. And what the pandemic has shown is that, that segment of the population is able to and loves it. And it's brought, not just value, but higher quality care because it's keeping patients in their homes or whatever care setting they may be in, which is huge because it reduces things like fall risks and other things that can lead to downstream, expenses and health events. So, I think that, I think this is a good first step. I think it needs to go further. And I think that piggybacking on what's been done in the ACO models and Innovation Center models is a good place to go, right? Because it has shown that, it's not just driving up volume of care in a way that's, creating waste in healthcare, but it's actually providing higher quality care and not more of it, right? And so I think that we're settling into that now, and that's great. And then it also encourages the external partner partnerships, and which is going to be a huge part too. So as this administration and as healthcare in general kind of refocuses on centering care around a patient and the primary care provider, and care meeting the patient where they are, both in terms of their condition, but also sort of their physical location, and having them in the right setting, I think that this is going to continue to have just really big significance going forward. I don't know if this is the right place to mention this, but we've been talking about it a lot from just the broader context of the regs. But one concern I have with the regs is actually with the part of them that is specific to the CMS models. So there are the specific exceptions for the CMS sponsored models. And my concern there is that before these regs, OIG had standalone waivers that they issued for each of the programs, whether it was the Medicare Shared Savings Program or the Next Generation ACO model, whatever it may be, they each had their own set of waivers that very clearly laid out what relationships were okay, both in terms of Stark, anti-kickback, and Benny inducements, right? So if what we're thinking about and really focused on is engaging the providers and then engaging the patients and then bringing that together, you have to know what you can do and what you can't do. And the waivers were actually, nothing's perfect, but the waivers were actually pretty darn good at that. And with this regulation, the expectation is that OIG is no longer going to issue those waivers for payment models or payment initiatives. And so what we have to stand on is this sort of high level language that is included in the regs, and it actually puts the responsibility on CMS itself rather than OIG to dictate what the terms are. And so what we've seen, sort of the first way this has played out is in the direct contracting model that went live on April 1. And, so again, there's no OIG waiver, and what we have are these regulations, and they're actually much more limiting in what the participants can do than what's been able to be done in the past, because it ties it to the providers that are actually participating in the model and the organization that's contracted with CMS. So it's much more limiting. And so I find that concerning going forward. So anyway, just wanted to get that out there.
No, that's really interesting. And, with the CMS administrator being confirmed yesterday by the Senate, over the next few months, it will be very interesting to see how she charts her course and what she chooses to revisit versus what she chooses to launch new things on, and the partnership with CMMI, sort of limiting the number of things that they launch. It's a really interesting time as any administration changes, but particularly with the CMS administrator just being confirmed. So Nichole, I want your take on that question, and then I'm going to start with you on the next one.
Sure. So I think Dave brings up an excellent point, right? These waivers had really delineated rules of the road that we kind of don't have today in the guidance that we've gotten, right? And so absent an advisory opinion, there's less risk tolerance to embrace some of these ideas. And I think there's going to be sort of a kind of a reckoning that comes into play where either, people are going to push forward and see what happens. And again, that depends on your risk tolerance, or you're going to find that this kind of innovative model and this cross collaboration that we saw as a function of the pandemic for virtual care and other things is going to kind of come to a halt because people aren't going to be willing to take on that level of risk with sort of such unknown in the administration, in HHS, and who, nobody really knows what's happening next. So, to the extent that there is some sort of direct guidance, like what you would see articulated in one of those waivers, I think that's really going to go a long way to continue the momentum that we built thus far in these external partner collaborations and a lot of the telemedicine work that's happened.
Very interesting. Very interesting. So Nichole, I'm starting with you on this one because, at Allina Health, I know you're sort of in a unique spot, right? You have the clarity into both the provider side and the payer side, but then you also have sister organizations that have similar partnerships across in a few other locations around the country. And so, my question here is, what kind of technology should patients expect to see incorporated into their care delivery as a part of these? And I think it was referenced earlier, the $500, I can't remember the term off the top of my head, but the within the patient engagement and support to improve the quality, health outcomes and efficiency safe harbor, what can patients actually expect to see from that?
I think, we've very long divorced kind of the payment mechanism from the actual care outcomes, right? And when you're in a joint venture environment where you're able to have shared data sources and a different level of collaboration, you've got things where you can connect to, your patient portal with the provider and also see your reimbursement mechanisms and your benefit structures to help consumers make more informed decisions. There's also an enhanced level of care that they can receive just because of the care coordination activities that happen as a function of the combination of both claims data from a variety of different providers, as well as EHR data from the providers that you have kind of in this more highly titrated performance network that's created by this relationship. And so I think consumers will get a more integrated, more cohesive experience that's more personalized, the specific nuances, both from a financial perspective and the way that they can pay for care, or care is paid for them, as well as in a way that care models and care plans can be created for them based on their very specific benefit structures.
That's great. Ashton, interested in your perspective on this as well.
Yeah, in terms of technology, I agree with Nichole, and I think for her response, I think if we had the data from payers to help us drive care forward, that would be a huge step in the right direction. And I think every payer is different in this case, but to be able to have a line of sight and a real-time line of sight into what is going on with this patient population, to be able to adjust as quickly as possible or innovate further is a critical component. So continuing to increase the infrastructure for our payer partners to allow for that data to be shared, for that open line of communication, is truly critical. I think it's not only giving the provider system a line of sight into what's going on with the patient, but also having the technological advancements to allow for the patient to provide us with a line of sight of what's going on with them at home. So with that $500 tools and support limitation, it begs the question of, can I send an iPad home with my patient to be able to look at their home, open their fridge, see what's in their cabinets to know if they're getting the right type of diet to prevent them from being in the hospital because a drug reacted poorly to them, or they're just declining in different ways because they can't get the social supports that they need to be able to pull in other partners. So I think that there are other there are other partners that are available here, but again, as the group has stated, it's how far can we go forward without having more information from the government on how some of those innovative models would be evaluated.
Interesting. And so, Matt, I'm interested if you have any insight into this, and then I'm gonna lead off the next and probably the last question with you. So.
Yeah, well, I think that, Nichole and Ashton nailed the two components that I think would be most interesting to me, and that's the mutual exchange of, patient information between payer and provider, and a robust EMR, because in order for these exceptions to kind of have any meaning in the marketplace for, risk arrangements, no one's going to enter a risk arrangement if they don't, well, if they're smart, they wouldn't enter into a risk arrangement unless they have ready access, to real-time accurate data, whether that's through, an EMR or some type of information health exchange platform, whatever the case may be. And, same with, the telehealth. They've got to be, patients have got to be able to access that benefit, and physicians have got to know how to use it in order for it to have a meaningful impact on the cost of care and the quality of care.
Great. That's helpful. And so I'm going to use this last question and then, answer it or use it to give your last word on this. I'm going to go to all of you, but, we've talked about this a bit, and it may be a little bit of rehashing a conversation we've already had, but I really am interested in this. And I think this is sort of the crux of where we're going with this webinar generally today is, what was left on the table that if it was implemented would be most beneficial to increasing the use of value-based care arrangements?
Well, to me, I think the biggest disappointment, stated another way, is the lack of commonality between the two sets of rules. And I think that more could have been done by the OIG to tailor their safe harbors to match the CMS exceptions. And I think that was a missed opportunity. I mean, I know OIG kind of sees themselves as the ultimate, I guess, security guard or safety valve for these arrangements, trying to avoid potentially fraudulent arrangements. And I guess they approached it from that perspective. But when you have, these 3 exceptions, which on their face look very similar, but once you dig into the detail, they're actually very meaningful distinctions between them and what you can do and cannot do. I think that CMS I think they both missed an opportunity there by not, using the same rules of the road for both.
Dave?
Yeah, I mean, on top of that, I would just say, and this is rehashing what we've talked about before, but for me, it's just detail and explanation that, the ability, sort of the practicality of being able to use them. So while, what they've done is open things up, they haven't necessarily opened them up in a way that is practical in terms of being able to use. And so having created this, like, we're going to wait and see and let somebody else do it first and see if it goes okay for them, sort of a thing, isn't really what you need to drive innovation and to drive care into value. And so again, I mean, I think it's great that it's out there. I think it's a great first step, but I think that, for me, that's the most difficult part. And then on the CMS innovation side, I just find it frustrating in now seeing it in practice with the direct contracting model, that we're not going to have separate fraud and abuse waivers. Because when I first read the regs, I thought, oh, this is actually nice because now CMS has enough authority that it can, and freedom that it can spell out what it wants and what it's going to allow. But the reality in practice is that CMS is still going to defer to the OIG and isn't going to venture into that world. And so what we've seen is what CMS puts out is actually pretty narrow and more limiting than what we've seen in the past. And when you go to CMS and you try to ask them, do you really want to be this narrow? Was this your intent? They won't even speak to their intent because they're worried about, running afoul of what OIG might consider to be okay. So I think that sort of gap is something that can be addressed, but needs to be addressed going forward.
Great. Ashton?
I think Matt really hit it for me on how there are discrepancies between anti-kickback and Stark, and really you need some kind of internal infrastructure to go through your innovative fact pattern and know if it aligns with an exception or a safe harbor, and you might fit into an exception but not a safe harbor, and what's your risk tolerance for that. So having future guidance on how this is going to work, again, that advisory opinion on how these rules will be applied is going to really be critical to allow the provider systems to start engaging in innovative models. That really is the intent of these final rules.
Great. And then Nichole, you get last word today.
Now, I echo all those comments because I think given the differences between the two that appear on the surface to be, very similar, you don't really have operational guidance or rules of the road that allow you to implement. And so we may actually get into what I deem to be a little bit of analysis paralysis, where nobody does anything because everybody's too busy analyzing sort of, well, is it going to work here? Is it not going to work there? And then, it doesn't really lend itself to really moving forward and implementing some of the innovative ideas that I think, this was trying to help facilitate.
Great. Well, this was a fascinating discussion. I really appreciate all of your time and insights. I look forward to, if not speaking with you again soon as a group, individually, as this continues to move forward. So thank you again. And thank you to everybody who attended today. We appreciate it. Again, this will be available on our website as to watch back, or it will also be available as a podcast in the coming weeks. So thank you, everyone, and enjoy your day.